Welcome everybody to the First Friday Addiction Toxicology Case Conference. It's August 6th. I'm Tim Wiegand. This is brought to you by the American College of Medical Toxicology and the American Society of Addiction Medicine as webinar partners. Please see prior FAQ pages on several of the webinars that were put together through a grant funded by the Opioid Response Network and include particular themes as you can access through the recorded sessions on both ACMT and ASAM. I'm Tim Wiegand, Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester Medical Center in Rochester, New York. And we have some distinguished panelists today. We have Joseph D'Orazio, who's an American College of Medical Toxicology expert, Associate Professor of Clinical Emergency Medicine, and Director of the Division of Medical Toxicology in the Department of Emergency Medicine at the Lewis Katz School of Medicine in Temple University, Philadelphia, Pennsylvania. Dr. Jean-Marie Perron from ACMT, as well, Professor, Department of Emergency Medicine, the Director of the Division of Medical Toxicology and Addiction Medicine Initiatives at the Perelman School of Medicine, also the Director at the Penn Center for Addiction Medicine and Policy at the University of Pennsylvania, Philadelphia, Pennsylvania. We have Dr. Kelly Ramsey, who's Chief of Medical Services and Associate Chief of Addiction Medicine in New York at the New York State Office of Addiction Services and Supports in Albany, New York. Myra Rodriguez Beltran, a guest expert and Director of Medical Services at Hugh Doyle in Rochester, New York, and Dr. Edwin Salsitz, an American College of Medical American Society of Addiction Medicine expert, who is an Associate Clinical Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai in Beth Israel in New York. None of our speakers have any conflicts of interest to disclose, and let's start with case one. I am going to describe case one. So this is un regalito, a little gift. Xylazine and illicit drug supply and a cluster of overdose deaths. And we start with going back to June, the end of June, and the University Hospital System as public relations has called to ask if I can comment on a cluster of overdoses that occurred over a weekend in Rochester, New York, earlier this summer, the end of June. You can see the headline from local media, Rochester Police, 3 found dead. This is at the same house. So someone called, found 3 individuals unresponsive. When EMS arrived, they were dead, apneic, not breathing, non-resuscitable. There was up to 18 other overdoses and at least 5 other fatalities around the city. This is around a 2-day period related to heroin use. And so there's a lot of interest in, what happened. We've had clusters of overdoses before, and we got a media request. And so my first question for the panelists is, what is your response to request for an interview related to overdose clusters and some pearls that you may have? Because I've certainly given interviews and learned several things from things taken out of context or messaging. And we'll start with Dr. D'Orazio. What is your response to media requests for something like this?
Yeah, I think it's very difficult. I think what media is typically looking for is like the sensational line that you to give, and oftentimes I sort of preempt them with that. I'm not in the field of doing that, and I'm not going to be able to give you a sensational line, but I can give you some background story. So sometimes that pushes away some of those media requests, but I feel like it's really important to have a solid message out there. So really being able to give scientific data behind it, whereas not saying something sensational like this is rampant across America and it's killing everybody, because that's what typically media interviews are looking for. But I would give, in this scenario, I would give some pearls about, its prevalence in our neighborhoods and how to manage it if you encountered somebody who had an overdose like this.
Yeah, that's great. Good comments. Dr. Perron, do you have any other suggestions? I know you've given quite a few interviews.
Yeah, I'd echo what Joe said. I mean, I think it's an opportunity for harm reduction and conversations about carrying Narcan. the ability to be a first responder to a family member or friend. And they actually just legalized fentanyl test strips in Philadelphia. So that might be another opportunity to broadcast that both to patients who use drugs and their colleagues and other people in the harm reduction community. So certainly anytime you talk to the press, there's an opportunity to say that, you know, these diseases are treatable. We have medications. We want to get people into treatment before this happens.
That's very good. Dr. Ramsey, do you have anything to add?
I don't have anything additional to add to this case.
Okay. Dr. Salsitz, any comments?
Yeah, I agree with everything, of course, that's been said, but my thing would be most importantly to use correct terminology and vocabulary and not to get into slang. And if the media is using addicts and junkies and crackheads and clean and dirty urines, it would be a good opportunity to correct that vocabulary, emphasize that these are people, patients, that it's a treatable problem, and to use medical terminology and approach it from a medical point of view.
Yeah, that's a very important point. And our media public relations department does a good job trying to screen out kind of the sensational reporters, you know, having, you know, a good feel on the pulse of the media in the area. I try and consider like three things, or even, you know, one or two main things that I want to get across, and I'll let the reporter know that, you know, I want the message to include this, this, and this. And, you know, in this case was not to sensationalize this, that most overdoses are related to fentanyl. Often it's just a higher concentration. That I wanted to remind people that we have a Good Samaritan law, so calling for help, and to have Narcan available, naloxone, to administer in the setting of overdose. And that they were really looking for, you know, what designer drug might be out there, what, you know, new things are you seeing? Have you seen? And actually, even before we knew that this was xylazine, they were asking during the interview what kind of adulterants and heroin have been, you know, seen. So I mentioned xylazine, but I actually had thought that this was just simply a cluster of fairly high concentration fentanyl bags that went around. We didn't have a lot of information on, you know, that any toxidrome or phenotype before that. So,
Tim, I do have
and then
one
there's some
point I wanted to make, and that's just that often when I hear people talk about overdoses, and I'm not talking specifically about addiction medicine providers, but providers in the community in general, I think a lot of folks think about doing overdose prevention only with people who are knowingly using opioids or who have opioid use disorder. And so I think it's really important that overdose education and prevention and provision of naloxone is done with anybody who's actively using any drugs, regardless of what their substance use disorder diagnosis is, and regardless of the substance they intend to use.
Yeah, that's a very important point, in particular with stimulants, but not just related to stimulants. So that's a very good comment. Thank you. I mean, this is some information from a police statement that was put out. You know, the comment was, while all illegal drugs are very dangerous, the Rochester City Police or Police Department are in particular warning the public about substances packaged as follows. And they, you know, describe the bag and the stamp, which I always feel is quite dangerous because, you know, historically patients feel that they will be able to tolerate this. This is really strong, and so I think that this is quite a dangerous type of messaging to get out to the community. And they had, you know, commented that they're increasing frequency that they're seeing overdoses and administering Narcan, and the death rate has eclipsed the prior year. One concerning comment was mentioned about naloxone, and they mentioned one dose is enough before, but now 2 or 3 doses are required to revive someone, which I think is somewhat of a misperception in that there's some caveats to that comment. And you know, so I thought this was a well-meaning message, but create some potential issues, and wondered if panelists had the same feeling, wanted to comment. Joe, do you have any thoughts? Or
yeah, you know, I think many people in our field understand that the Narcan resistance has a lot to do with polysubstance use, and so that there's a combination of medications. And so the message I always try to send out to people is that you're trying to reverse the respiratory depression. But when it's going to the community, that can be kind of difficult. But I think what I like to convey is that typically starting with one dose and checking for breathing rather than did they wake up. I think that's a message that I like to send out. And then I think maybe I want to leave enough other stuff for other people to talk about, but I always worry about the tourism effect that happens when there's an alert that goes out with a specific bag in particular that's causing multiple overdoses, especially in my community where there is a lot of drug tourism. People are coming in from far away to use in my neighborhood. But I think on the reverse side, the community needs to have that information. They need to have the information so they can stay safe. So there's a balance there. And I think the better way to do that is by credible messengers on the ground to the people in the community rather than being sent out on social media or on TV. I think that's the way that you end up having more drug tourism than actually looking to save the community from overdose.
Yeah, those are great points. Maybe a really good role for peers in the community or boots on the ground. Does anyone else want to comment on this? Dr. Perrone?
I think Joe mirrors my thoughts as well. So thanks.
Okay. Dr. Ramsey?
Nope, I thought he covered it well. Thanks.
Okay. And Dr. Seltz, any other comments, thoughts?
No, I have never actually witnessed an naloxone overdose happening outside of the hospital, but I would think people would be a little bit nervous and agitated, and I think that the name of the game is that the person doesn't die. And I know there's been some discussion by Dr. Nelson and others about not using high doses of naloxone because of the problem with precipitated withdrawal. But I think out on the street, the name of the game is to save the person's life and get him to the hospital.
Yeah, and I think that's important messaging as well. I can tell you, seeing patients that get 3-4 milligram doses in rapid succession, and there's 30 seconds in between each dose. I tell people when I'm talking about Narcan, make sure you take your own pulse too, because you give the dose and you've got to turn on the side, watch for the breathing, and the frequency of polydrug overdoses is really, a valid point. We're not, not everything can be reversed by Narcan, and really severe precipitated withdrawal has significant medical complications potentially. That said, making sure the patient gets Narcan. I haven't seen a resistance with naloxone when there's an opioid there. So, Myra, did you have any thoughts to the community or to the alerts you want to comment at all?
Sure. So I think that what you just said about, making, a lot of times when multiple doses are needed more than the standard 2 that come with the Narcan kit is because it's given too quickly and it hasn't been given enough time for it to work. I actually responded to an opioid overdose that happened outside of our, in the street outside of our clinic. And it was I've trained millions of people, probably not millions, but a lot of people on how to respond to an opioid overdose, but I've never had to do it myself. And being in that position, time goes by so slow. And we did end up giving 3 doses, but I think when I think about it, after the fact, 2 doses probably was going to be okay. It's just we gave it too soon, too quick.
Yeah, I could comment on that too, Tim. I have also been resuscitated people outside of the hospital with intranasal Narcan. And, for those of us who have practiced a long time, IV naloxone is, one of the best antidotes we have. And that's why the low doses can be used, because it's incredibly potent and works quickly. The intranasal naloxone is 4 milligrams, but such a small amount of it actually gets absorbed. So it's really misleading that you're giving a higher dose and people are waking up more slowly. It's just a very different onset of action. So I can see why people would do 2 doses more quickly, because as Myra said, it does seem like a long time if you're doing CPR on a subway floor. But it does ultimately work, if it's going to work even after the 2 doses. So it's a very different analogy than the 0.1 milligram that we can give in a hospital with a good IV access.
Yeah, that's a good point. There's also situations patients may have pulmonary edema, stuff in the nose, and the barriers to actually administering the intranasal naloxone to actually getting it to the absorption. So there's some caveats certainly with that. So great comments. Thank you all. All right, so let's go into the case 1. So this is a 37-year-old male with opioid and stimulant use disorder with IV drug use using 2 bundles of heroin and cocaine a day. He's brought to the emergency department after an overdose. He was found in an area of town where there's a lot of street level drug use, and apparently leaning against a porta pot on a construction site. And a bystander who had been watching him thought he looked like he'd been using K2, synthetic cannabinoids, which is pretty common in the area as well, but wasn't really moving around. And after kind of watching him for a period of time, he called 911. Was worried about an overdose. EMS finds him unresponsive, and he's leaning against the structure, like held up by the structure. He's breathing, but has some bradypnea and snoring respirations. He has meiosis. There's medics note that he has stigmata of IV drug use in his left neck and both arms. He's actually holding an empty syringe in one of his hands when he was found. They administer intranasal naloxone, 2 doses, or EMS first responders had administered naloxone. Police were there as well. It wasn't clear who had administered the first and second dose, but he did get 2 doses. And there's documented improvement in the respiratory rate, but he remains lethargic, and his paroxysms of retching, vomiting, and yelling out is still lethargic. Transported to the emergency department. The first heart rate that documented is in the 50s and remains in the 50s and 60s. As he's brought to the ED, the patient's vomited twice, but then has a lot of retching, frequent bouts of retching without emesis, and he's still lethargic. In the ED, he's monitored on telemetry with pulse ox, kept in soft restraints due to the intermittent flailing and occasional lurching forward. There's some consideration of giving him a benzodiazepine, but because of the lethargy, and he's breathing, and he really doesn't need more than just kind of soft restraints and reassurance. It's not just consistent agitation. He's just simply monitored. His heart rate's in the 50s, blood pressure's in the 80s, 90s, systolic 60s, 50s, 50s, 60s, diastolic. He's given fluids. He has meiosis, heavy IV drug use stigmata on the left neck and both arms, an area of ulceration on the left leg with signs of early cellulitis and IV puncture sites as well, and a dorsum of the foot, lower leg. And he's got old scars on both lower legs and arms. They're healed, although some have some more recent attempts at injection sites and puncture wounds. His white count is 21. His chemistry shows a bicarb in the 17s. He's got an anion gap of about 21. 20. His B1 is 22, creatinine is a little bit up at 1.4. His CK is 450, glucose 220. And so what are your thoughts about this overdose, the response to naloxone, and discuss, the findings, what they suggest? So really any comments? And again, I'll start with Dr. Gilrazio.
Yeah, I think this is a pretty typical presentation. And I think in my community, what like maybe 5-6 years ago, what I would have been talking about was this person probably has also had used, benzodiazepine, and that's why they're not, waking up to the Narcan. There's another drug on board, and maybe the bradycardia and hypotension has something to do with addiction treatment adjacent drugs like clonidine. Who have caused some bradycardia and hypotension, and that this person just needs continued supportive care. Yeah,
that's good. I've also seen some myocardial stunning if there's a stimulant, or even, if this would bad precipitated withdrawal, I've seen some stunning. So, but yeah, clonidine is a frequent co-prescription, and gabapentin, baclofen, benzodiazepines. There's a lot of prestolparazolam with designer benzos, and so very good points. Any other comments, Dr. Perrone?
Yeah, I think it's hard to advise people. This patient may be just okay and just needs that supportive care and kind of preventing people from trying to give more naloxone or do more things that might be more detrimental. So I think it's a good reminder to, if you think he's safe as he is, to just let him continue with close observation and maybe not any additional interventions.
Yeah, and he's now in a secure setting where they can either give very low doses in naloxone if he starts to have more bradypnea. He hadn't started to get some workup for infection. His white count was up. He was not febrile. Dr. Salsitz, do you have any comments?
I agree with continuing the observation and supportive care. And it strikes me that as we speak now in August of 2021, people buying illicit drugs of any kind, neither the dealer nor the person using the drugs really has any idea what's in the drug, what the adulterants are, what the contaminants are, whether they're active contaminants or inert contaminants. It's really a crapshoot now, buying anything illicitly on the street, whether it's powder or tablets or liquid or whatever.
Yeah, very pertinent. Certainly buyer beware, caveat emptor. Dr. Ramsey, any comments?
Nothing additional. I particularly agree with what Ed just said.
And Myra, do you have any comments on?
Nothing additional, thank you.
Okay, thank you. We continue. So this patient does improve over the next 2 to 3 hours with just simply monitoring. He has a little bit of a drop in his respiratory rate as he falls asleep, but he's maintaining his oxygen saturation, so he was not given additional naloxone, and he wakes up and he's given a little bit of a sternal rub, and then to voice within 1 to 2 hours. He's getting some fluids, some thiamine. He wasn't given dextrose. He has glucose in the 200s. Repeat chemistry is ordered. Evaluation for infections ongoing. And as he's waking up, he says he used a little bit too much. Denies using a synthetic cannabinoid or other drugs except for cannabis and tobacco. And he says there's a new cut in the heroin. It's made it harder to estimate how much to use, but he used it previously when he lived in Puerto Rico 5 to 6 years prior. And he says that's where these are from, and he's showing these areas of ulceration. And so what is the cut, and what is the association of the wounds, ulcers to it? And what's your experience with the fentanyl, heroin, and other drug adulteration now with what this cut is? We have it in the title. So what are clinical implications, and any other comments? And again, I'll start with Dr. D'Orazio.
I think this is a common theme that we have to answer questions about often. In the past, this is the story that I typically hear. In the past, it was heroin, and we used it a couple times a day, and there was no problems. But now that there's all these other drugs in there, we're seeing more and more abscesses, wounds, infections, and I think it's something that's in the drug. And initially it was blamed on fentanyl, and then I think there's people that are saying, oh, there's crocodile or desomorphine that's out in our community that's causing it. And now the latest one, people are saying that it's from xylazine. And I don't think that I have a lot of information that says that xylazine necessarily causes that. And but that's a lot right here from the street. I think it has a lot to do with maybe the behavior of how people are using. People once using 3 to maybe 6 times a day at most, and now people are using 10, 12, 14 times a day, and they're just injecting that many more times. And then there's some reaction to that drug that causes more of these wounds. People are unconscious for long periods of time, and they're injecting that many more times, so there's that many more bacteria under the skin, and we get these like vasculitis that happens from the multiple injections, and then that's why we're seeing so many more wounds and ulcers. But I mean, who knows? Maybe it is the xylazine. I just don't think we've got a lot of information about what would cause it. I think sometimes my first thought is there's some caustic agent that's in this that people are injecting, and I just don't think that has been proven just yet.
Yeah, those are great comments. We've had some increasing injection of crack cocaine in our area, which I see really severe thrombophlebitis and wounds as people dissolve it in vinegar and even lemon juice and lime juice on occasion. So, and then, this technique or more frequent use, adulterants and particulates, certainly. He was pretty convinced that the wounds were from his, the use because they started, but certainly there's other reasons why people may have. And I think all of us have heard, that this patient has really severe wounds. I think they're using the crocodile, the desomorphine, desoxymorphine, and, they trained in California where the heroin was all black tar and would see wounds that rivaled those of the experience in Russia where people were actually making the desoxymorphine or crocodile. So, people can have wounds from IV drug use that are pretty severe. Any other comments, Dr. Prone, and your experience?
I'm not quite sure if I heard Joe say it, but I've heard him say that, both fentanyl causing maybe pruritus and then methamphetamine use causing more, picking at the skin and more things that start an ulceration or start the scratching and progressive, breaking down the barrier of the skin in various places. So I think that probably also factors in. But I mean, I've been practicing for a long time and we've always had wounds. And now we just have a lot more patients using, drugs. So I'm not sure that we're seeing a different pattern in particular.
Yeah, that's a good point about the methamphetamine and stimulant picking. I see that with cocaine, but methamphetamine in particular, as people are up and excoriations can get really severe. So good. Dr. Salsitz, any other comments?
Yeah, since I recently reviewed the topic, when you mentioned Puerto Rico on the previous slide, that kind of lets the cat out of the bag. This seems to be more of a problem in Puerto Rico in terms of the xylazine association than in the United States. And what I've read in the papers I reviewed is that the reasons could be that the xylazine is providing analgesia around the wound area and people are picking at it and not feeling the painful part of it. And the other thing that the papers point out is that there may be a hypooxygenation environment around the wound because of the hypotension that the xylazine may cause. This week down here at Mount Sinai Beth Israel, we've had tramadol and oxycodone in people who were not looking for it, weren't taking it, buying heroin contaminated with fentanyl. So I think these agents are going to keep changing. And I know that the medical toxicologists are doing a national study on what is in the drugs that people are coming in with. But we haven't seen tramadol here very much. And we had a number of cases this week.
Yeah, that's a good point. That was identified. Tramadol, xylazine, some other agents through the study by Benini and ACMT. Sites throughout the United States will be interesting. It's a 5-year longitudinal study. One of my thoughts for the ulceration in particular is xylazine has alpha-2 agonist effects, and there's some overlap with the alpha-1 receptor. So vasoconstriction, if there's some extravasation, it makes sense that there would be increased lesions with lack of blood flow. I mean, we use alpha-2 agonists topically for scleritis, for epistaxis. So if someone injected an alpha-2 agonist, there would be decreased local blood flow. That's one of my thoughts. And I know there's some others at the bradycardia, hypotension, tissue perfusion, but certainly there may be some other reasons. And I don't think that this has been certainly proven, but wounds, at least at the street level and the culture, people are associating it with, so they tend to be heavy substance users as well. Dr. Ramsey, did you have anything you wanted to add?
I actually don't. I have not encountered xylazine in my practice. Certainly when I was practicing in an OTP in the city and we had a large population from Puerto Rico or who were Puerto Rican back and forth to Puerto Rico, I saw a lot of cases with levimicil as the cut, but I have not seen that.
And Myra, do you want to add anything? I know that you've had some experience with patients in particular reporting their use.
Nothing further to add. From our Latino clinic, I've had patients tell me about anesthesia, anesthesia de caballo, or, the horse anesthesia, as they call it, as being something that was very popular in their days of use in Puerto Rico. It wasn't until recent that it came to this area, but nothing else to add.
Right. I think my first experience with it in the Rochester area was an individual's family had performed an intervention, gone to Puerto Rico and gotten their son, who was on the street in Puerto Rico, and brought him back, and he had been using the heroin with xylazine, and ended up treating him with buprenorphine and clonidine. But he was displaced certainly from Puerto Rico to here. It wasn't from the local drug supply. This was 4 or 5 years, maybe longer than that. But it's only recently that we've seen it in our area. So this patient is interested in help, and he's been on buprenorphine and methadone in the past, methadone while in Puerto Rico. He's worried about starting buprenorphine. At this point, he's had precipitated withdrawal several times trying to take it in the street over the past few years. He's also worried about withdrawal from the xylazine, asks about that. He feels he's been using both for pretty consistently more recently. He also uses cocaine. So what are your recommendations for treatment for this patient? He's probably not going to need a prolonged hospital stay. And, whether there's xylazine or not, it's a challenge to start buprenorphine before this patient is leaving the hospital. So I'm wondering what are your recommendations? What about the xylazine? Is there a withdrawal syndrome with xylazine? How is it treated? So Dr. D'Orazio, what's your experience with this, and what would you do?
So we see a lot of this in my community, patients who get admitted to the hospital who, they are experiencing opioid withdrawal, they get buprenorphine, they're starting to feel better, and you can certainly tell from their multi-system symptoms they're improving, but the anxiety sort of sticks around afterwards. And I link that a lot with the xylazine that we're seeing in our community. Not vomiting, not feeling sweaty anymore, no more yawning or piloerection, but you just can't get rid of the severe anxiety that people have. And I think that is due to the xylazine withdrawal that people are experiencing. Certainly, if you look at other drugs that are similar to xylazine, like dexmedetomidine and clonidine, there certainly is a withdrawal syndrome that's associated with this. But I think when we're talking about xylazine, we're talking, an order of magnitude higher than those drugs that are used, like when we're talking about xylazine or clonidine. And so there's just lots of anxiety that's associated with this drug. And so my typical approach is to add a benzodiazepine to the care for a few days while we're continuing to stabilize that person in the hospital. I think in more severe situations, adding other adjunctive medications are really helpful, but then maybe you could even bump up to something like phenobarbital too. I think
that's interesting. What about?
I think the first thing that people are going to ask, and I imagine this was going to be your question, why not clonidine? And
that was an ask.
And I have not found much effect with that. Certainly, I think we're just using the wrong dose. But the thing is, if we use any higher doses, we would see a lot of bradycardia and hypotension. So it just doesn't allow us to, there's a ceiling to that dose. Because I'm seeing people try to use it at 0.1 milligrams TID, or maybe even 2.2 milligrams TID. And I think that, like I said, it's probably got to be an order of magnitude higher to get the effect that you're looking for. But then you're going to see way too much bradycardia and hypotension with that.
It's interesting. I have not treated in a lot of xylazine withdrawal, but I have used clonidine, much of the time, a few times it's been started, and then, the patient takes a prescription outpatient, and several are lost to follow-up, as was the case with the patient that was brought back from Puerto Rico. But, it would seem I treat dexmedetomidine wean dependence and patholytic dependence with clonidine fairly frequently, in particular with COVID, as patients required really high doses for prolonged periods, had iatrogenic dependence to opioid sedatives, and some patholytics developed. And it seemed, for dexmedetomidine, clonidine was effective high doses, up to 0.3 4 times a day, use a patch, maybe in combination. Why don't you feel that the clonidine would be effective for xylazine? It's a different animal from dexmedetomidine in addition.
Yeah, I think it sort of works in the same relative way, as in it's blocking catecholamine outflow, but I think it's just working in such a higher. I think the dosing that we're getting is so much higher from than clonidine that you just can't match that effect with clonidine. And so we've tried 0.2 milligrams TID. Even one patient we tried 0.3 TID, and it wasn't really working so well. And I've seen not cases I'm necessarily involved in as in recommending, but consulting, and I've seen they've already put the person on clonidine. They have significant amount of anxiety, and the only thing that has gotten rid of that anxiety is benzodiazepine. And they are clearly not an opioid withdrawal. Like the opioid withdrawal portion has been satisfied, and it's just left with single system problem, which is anxiety.
Well, that really has implications as people become dependent, not just simply on the opioids of xylazine, but there's use concomitantly with cocaine, and then use the withdrawal and mono use. I've had colleagues describe mono use. So, any other thoughts, Dr. Perrone? Do you have anything to add to that?
I had wanted to comment a little bit earlier when we were preparing something on xylazine. I reached out to my colleagues in Puerto Rico. Joe and I had a toxicology colleague who was one of the authors on that paper from 2014, Dr. Jose Diaz, who runs the poison center there. And he said that their xylazine use has really quieted down, and there really haven't been any follow-up studies, and that's really not so problematic. So I'm not sure, of all there's just a lot going on, with a lot more substance use in general. But certainly here it's very much on the forefront of our patients' minds. And I feel like a lot of the anxiety around precipitated withdrawal may also be an exacerbation of xylazine withdrawal or xylazine anxiety, however you want to characterize that exactly.
Well, that's interesting that they feel it's decreasing in Puerto Rico, at the same time increasing here. Dr. Salsitz, do you have anything you want to add?
The only thing I was going to say, I think you said, and I was wondering when Joe was speaking about leading in with PO clonidine and then using the transdermal patch, but you mentioned that. I've had no experience with xylazine withdrawal.
I think in our community, it really has supplanted benzodiazepines as the sedative agent. And actually, you can see that in the data from our medical examiner that the amount of benzo positive screens at autopsy is coming down, and the xylazine has come up, and they've kind of met in the middle now.
Yeah, that's interesting. We're still in the wave of benzodiazepine. There's so much benzodiazepine and other GABAergic agents in our area. Dr. Ramsey, did you have any other comments?
Nope, I don't have anything additional here.
Okay, so the patient agrees to start a microinduction, which is starting very small doses of buprenorphine. We use the first dose before somebody's even in withdrawal, 150 micrograms, 6 hours. And there are variations of this. As this patient has stopped using, we could go much more frequently. He's watched overnight for 24 hours. He really hadn't gone into withdrawal by the second day. And he's asked if he can complete the induction at home. He's got a follow-up at a local clinic that can use telemedicine for observed doses as additional support, and also is familiar with microdosing, microinductions. So I know there's variations in how people do microinduction. He had received 4 doses. Dr. Perrone, what would you do, and what have you done with microinduction? Any comments to this patient?
Yeah, this is, I think, an exciting area because we really need to get people onto buprenorphine and overcome this, the concept that patients, quote unquote, say bupe doesn't work for me, and it's, it's our best tool for many of our patients. And so they have heard of microdosing on the street, which helps a little bit. And so they're prompting providers to be more flexible. The protocol we have right now starts with 450 micrograms of Belbuca in the ED, and we encourage them to take that first dose in the ED. These are for patients who are going to get discharged. And then we continue. We have actually we have a 7-day pathway that I think is a little too long, that we're trying to condense closer to a 3-day pathway. But once they're out of the hospital, we have them take 2 milligram strips and cut them in 4 pieces, which, as many of you know, is not allowed in the hospital. But we prescribe about 28 sublingual 2 milligram strips, and we have them cut them into 4 and take them initially to BID and then 4 BID, and basically accelerate up to 16 on day 6. And of course that presumes that the patient continues to use fentanyl, which is obviously not ideal. That's why we're trying to get it to a little bit faster. I think you can go as quickly as, Q3 hours in some pathways, but we're trying to adapt to the feedback that we're getting from patients.
That's great. There's so much patient variability, and it really depends. Are they able to stop, or are they continuing to use? And, in a patient that's able to stop, I've in the ED gone very frequently with 150 Q2 hours, 300 mics Q2 hours, 1 milligram Q2 hours, 2 milligrams, and within an afternoon. It's fairly labor intensive, and really requires an order set, which we have an order set for a different microinduction, but it can be done, but patients need a lot of hand holding, and the key is if they do this once or twice and get safely on it without precipitated withdrawal, then getting that out is really important, because I think this is really the technique that in the era of fentanyl adulterated heroin, you need to use to get patients on. Otherwise, we're seeing so many more precipitated withdrawal cases as patients try to restart if they've gotten off, even coming from the detoxes, where they are maybe not able to get the Belbuca or cut at 2 milligram into 8ths or 16ths or even quarters. Any other comments, Dr. Ramsey?
Nope, I don't have anything additional here.
I'd say just for the detox, we see a lot of patients admitted who get methadone 30, 20, 10 and discharge. It's kind of a terrible strategy. And the detoxes are telling us that the patients don't want Suboxone. But we're encouraging them to have a rapid methadone cross taper where they just get the methadone for 3 days at 30 milligrams, but they start the BUP on day 1. So that they're really cross tapered during their detox, whatever you want to call it, short hospital stay, and at least discharged with buprenorphine, since we know that being discharged with no plan and no meds is, so dangerous.
I do want to tag team onto what Jean Marie just said, because that did make me think of something I did want to say, which is that, as we all know, detox isn't treatment, right? Detox is just a moment in time to stabilize a person. But as Jean Marie just said, if you discharge them without a plan or without ongoing medication, we know that their risk for overdose is really high. So a lot of times when, I'm in a policy and regulatory position in New York State. So when we talk to programs and say there's an overdose death from someone who's been released from a program and they aren't on medication, and we ask them why the patient wasn't on medication, and the response is often they refused. But again, what does that refusal mean? And how is that refusal addressed? And how is that patient talked about with respect to medication? Do they address any, for example, internalized stigma that person may have around medication for addiction treatment, or do they address issues? Do they inform them about their decreased risk for overdose if they're on medication? So it really takes a thoughtful and nuanced conversation with a patient who refuses medication to determine exactly why they're refusing medication. And if you take the time to have that conversation, often the patient will change their mind.
I agree.
Yeah, no, those are great points. Yeah, I've even pulled up microdosing, some posters and things for patients to show them that, that they've kind of heard this, and look, here's some cases, here's some discussion, here's some literature. And stressing, my goal is not to make you feel worse. It's to try and help you feel better. But some great comments. Dr. Celsus, did you want to add anything?
Yeah, I wanted to say, Tim, that UED folks and toxicologists are driving me crazy. One day it's microdosing, and then I just read a couple of articles on macrodosing. Don't worry, give people 8 milligrams or 16 milligrams the first dose. And in the paper just published, the reported precipitated withdrawal was 0.8. So I'm an old fogey. I'm still going more along the lines of classical induction. And I don't know, micro, macro, which is it?
That's an entire hour, if not longer in itself. I think you get into hand, because macrodosing, in my experience, if someone's not in withdrawal, precipitates withdrawal. If they're in precipitated withdrawal or have just gotten naloxone, a big dose of buprenorphine is going to be okay. But if in this patient, if he would get 16 milligrams of buprenorphine in the ED, he's going to be very sick and leaving AMA. So I would like to see that paper.
Yeah, I definitely agree with you, Tim. And just to clarify, Ed, that article was published in California, and all of their patients are, for the most part, were using black tar heroin in the era when, fentanyl was just emerging, even though they have some fentanyl patients in there. But it's a very different, I know that patient population well, and I'm not as supportive as macrodosing, just like Tim just said. So I know it's out there, but it's hard to interpret what we should be doing right now.
Yeah, I won't do it unless somebody's in precipitated withdrawal and they're like at their worst, then we need to get them out quickly, because the patients come into the ED telling me they took 12, 16 milligrams, on top of fentanyl, and they are sick. So macrodosing by the patient is not working when they're not in withdrawal. Let's move on, because we have a couple of slides, and we already talked about microinduction. This patient was given clonidine. In the hospital, he did okay, but he left within 24 hours, and so to Dr. Durazio's point, it may not have been enough. But I do use clonidine. I really don't want to discharge a patient with a benzodiazepine using potentially fentanyl, returning to fentanyl, and hydroxyzine. He really didn't take hydroxyzine. I have a couple of different examples of microinduction protocols just for the slides if people are interested. There are variations, and again, this is an evolving area. We have a few minutes, Dr. Salsa, so I'll have you just provide some background on xylazine, and then we'll want to get to the second case briefly, which is a very much shorter end of the case, so we can finish on time here. So I'll turn it over to you. Tell me when to advance the slide.
Tim, I'm wondering, for the sake of time, we've done a lot of the didactic stuff that's on the slides. I wonder whether we might just move along without them, or do you want to go through them? I think we've talked about it through our discussions. But okay.
No, I'll go very quickly if you tell me what you want. I mean, we've already covered the mechanism.
Covered this, I think we've covered this.
The chemistry.
That's for any biochemists who are on the call. I think if you talk to anybody from Puerto Rico, they just know about xylazine, and they call it anesthesia de caballo, which somebody's already mentioned. And the ulcerations seem to be happening more in Puerto Rico than at least in the United States. And we haven't talked about the veterinarians in particular, and they have a vulnerability because they have access to the xylazine, usually not as a combination with fentanyl or cocaine or heroin. But if somebody does work in veterinary medicine and does have an overdose, it's something to think about.
Yeah, very good. Thank you. And you've had a couple of cases in your NISAM presentation where it was used to facilitate sexual assault and some other areas. So,
right. Many routes of administration,
including one novel one. Unfortunately, a gentleman was exposed to xylazine after eating elk. Apparently, there's a case report on that.
Yeah.
And
on this slide, I do find interesting, and I'm particularly interested in the comments that Joe has made, because it's difficult with the meiosis to not think that you're dealing with an opioid overdose. And I don't know how often the hyperglycemia occurs, but that seems to be one of the only clues that it might be xylazine, or maybe the alpha-2 adrenergic agonists in general.
It could also be the stress response if somebody's gotten naloxone. Dr. Durazio, do you want to comment on this toxidrome, this slide?
Briefly? I think probably the receptor that we need to be concentrating on here is the imidazoline receptor. And so with things like oxymetazoline, tetrahydrozoline, clonidine, dexmedetomidine. There's lots of bradycardia and hypotension, so it's like that one side. But from my understanding, xylazine doesn't have a lot of imidazoline receptor activity, and so this is why we don't see much bradycardia and hypotension. I got to say that I see a lot of heroin overdoses in my emergency department, and it is a very rare case to see somebody that's bradycardic and hypotensive. And you would think that with all of the xylazine in our supply, and the DEA tells me that it's nearly 100% of the fentanyl is linked with xylazine in my neighborhood,
Wow.
that I'd be seeing a lot of bradycardia and hypotension, because I see people that come in post Narcan who are still sleepy that I think are due to the xylazine effect, and they're not bradycardic and hypotensive. So I think it's maybe a misnomer or like a miscommunication about this bradycardia and hypotension with xylazine. But I get it because it's, you know, a derivative of clonidine, so everyone would expect bradycardia and hypotension to be occurring.
Yeah, and this gentleman had that, although there are alternative explanations studying co-ingestion, but it'll be interesting as you have such a frequency of xylazine to really compare the forensic to the clinical phenotype. There's some data from poison control centers from 2014 that describes symptoms and findings. Bradycardia is present in about 20% of the exposures, with other substances, 27%, and treatments, mostly supportive care, really. This is from 2016. This is from Dr. Salsit's lecture showing images of the ulceration in street users of polysubstance in Puerto Rico, Journal of Urban Health, 2012. And from New York City syringe exchange programs in 2017, Dr. Logan and his group published data on the residue analysis and found xylazine in 2.2% of the syringes. 77% were positive from one or more substances, 23% negative, but again, maybe rinsed or not used. And this is data from Philadelphia that shows the increasing frequency that xylazine is found with testing of heroin and fentanyl. 2015, 5%, 2019, 25%. It sounds like what from Dr. Razio and Dr. Corona are mentioning, that we're close to nearly, 100%. This is an interesting slide on the image on the left that I've got highlighted on the next slide that looks at the fatal overdoses and the percentage of deaths where xylazine is also present with fentanyl, and increasing obviously from 2000, similar in terms of the prevalence where it's found. Dr. DeRazio, Dr. Perone, do you want to comment on these slides, since you're from Philadelphia in particular, and what would be found in 2021?
I mean, probably, continuing to trend at least at the same rate. As everyone knows, overdose deaths in general have gone up about 35% in around the country. So we continue to see that impact. It actually has changed a little bit demographics and location in Philadelphia. So there's been a bigger impact in communities of color, which has been a shift in our use. I expect that xylazine will continue to be present in the fentanyl. We're still finding a lot of fentanyl in cocaine, which is also why it's affecting these other communities. I don't know if there's fentanyl and xylazine in the cocaine, probably is. But in that case, I would expect this number to continue to go up.
And we've got really one final slide related to this case. Any other experience? Why would it be? You mentioned cocaine, so why would it be combined with cocaine, do you feel? And then, has anybody seen mono xylazine exposure dependence? Any other final comments? I'll start with Dr. DeRazio.
I've had one patient who told me he was just using xylazine, and he was able to show me a bottle that he had used, that he brought in, that he was getting. So it's available out there for people to use. I think it's at like a very high level that it's not necessarily readily available to the end user. But that's what's actually getting mixed into the bags of heroin and fentanyl in my community. It's pharmaceutical grade or veterinary grade xylazine. It's not something that's made from precursors. So it is available as mono product, but I've only had one patient who has told me that he was using it as a mono product. I'm not quite sure why it would be used with cocaine, in conjunction with cocaine. I have never seen anyone who was using cocaine and xylazine. It has really been, opioids and xylazine, and then maybe plus cocaine. But I think the idea of a speedball, I think everyone can really understand what's going on there. Maybe even mixed with methamphetamine too.
Also, from the dealer's perspective, to create a dependence, where you don't have the dependence with cocaine and methamphetamine, of the physical, at least, withdrawal. Maybe there's some profit incentive in returning, necessity to return, but that's more to be seen as data comes out from areas of the country that are particularly hit with xylazine. So thank you all. Let's move on to the second case, which we're quite a bit less time, but I just we're in a new era of COVID, and wanted to talk a little bit about vaccine hesitancy and substance use disorder treatment. I've said this many times, trust me, COVID-19 can be much worse than any reaction to the vaccine. So I got 3 cases, not just a case, and it's just a simple summary statement. A 47-year-old male discusses his hesitancy in getting the COVID-19 vaccine during a follow-up telemedicine visit with his provider in an outpatient substance use disorder treatment program. He's described buprenorphine naloxone 8/2 twice a day, and he's hesitant to get it because he's heard it's not safe. They talk about it at my church. He's Puerto Rican, and he has got very close-knit friends and church group that he gets a lot of support from, but he's consistent in saying that he just doesn't feel it's safe, and they discuss it at his church. The second patient is an African-American male who says, and he says, "Doc, I trust you, but I don't trust the system." And the third is a 24-year-old Caucasian male adamant COVID-19 is not a big deal. So none of these are getting the vaccine. And what is your experience addressing the hesitancy or resistance in your patients? And if you had particular opportunities, increased availability to persons who use drugs or individuals in treatment programs, and in general, what percentage of your population you believe is vaccinated for COVID-19, and how does this vary by demographic? I'll start with Myra. You've got some comments, I know.
Yeah, so with vaccine hesitancy, what I found is most of my male patients are the most difficult to convince for whatever reason. They come with these ideas that it's not safe. Most of the ideas are based on like microchips, or they're tracking me, or things that I'm not able to convince them otherwise. But I found that most of the patients I'm able to convince. About 80 to 90% of the unvaccinated people that I talk to about the vaccine, I'm able to address their questions. They're probably just waiting for somebody in the healthcare field to just talk to them about the vaccine and why is it safe, and just waiting for like a go, and talk to them about where they can go and which one of the 3 that are available is the safest for their situation. So I found that after having that conversation, I am able to convince most patients to get about 80 to 90% of the patients. In the second question, what opportunities? I found that if pharmacies have been very helpful, especially if I'm prescribing medication. It's just like, when are you due for your medication? All right, well, let's look at if you need to schedule an appointment. We'll schedule an appointment on the same day you're due for your fill, or this pharmacy doesn't require an appointment, so you could just ask your pharmacist when you're there to pick up your medications anyway. So that's been very helpful. And also being aware of community events, or there are some community programs that are doing incentives. They give like a $50 gift card, and for somebody that could be very enticing in getting the vaccine. But I found that from overall, about 60% of my patients are vaccinated, and from the other ones, I can convince about 80% of them.
Very good, thank you. Dr. Ramsey, you've been involved in some outreach and got some comments related to this.
Sure. So actually, if we could go to the previous slide, because I want to address each of those scenarios. They're different. And so the number one thing is that this takes time. So this is not a one and done conversation in most settings. This is something that again is nuanced. You have to look at the individual's own risk benefit profile. And I don't tell the individual what their risk benefit profile is for them as an individual. I let them tell me what their risk profile is. So often that's based on their comorbidities and their race, ethnicity, and their access to healthcare, et cetera, et cetera, et cetera. So for the first gentleman, it's really interesting. Where are people getting their information about the vaccine? So are they getting it from people who do not have a medical background? Are they getting it from Facebook chat rooms? So steer people to where information is reliable. Now, sometimes if people really do have a lot of conspiracy theories around vaccine hesitancy, then they're not going to trust what we consider good informational sources like the CDC and the New York State Department of Health and the New York City DOHMH. But it's important that we talk about factual information with people. So interestingly, with people who do not want to get the vaccine, their main concerns are around safety and efficacy, and there is so much safety and efficacy data. So it's really important to go over that data with people. Their main concerns are actually not about COVID itself, or maybe it's a lack of perceived risk with respect to COVID-19. So focusing on COVID-19 risk has not been an effective strategy with most patients. So that's just a little bit of how I would handle the first individual. The second individual, so with persons of color, particularly the African-American community and the Latinx community and the Native American community, there's been a history of medical experimentation in the United States. So you can't just brush that concern under the carpet and say like, well, what do you mean you don't trust the system and the government? There are legitimate reasons why they shouldn't trust the government or the medical system because of what has happened historically and that historical trauma. So it's important to recognize that first, acknowledge it, but then talk about the facts with this vaccine. And specifically in this scenario, who is most convincing, and this is what Myra just said, who is most convincing is your own medical provider. That's probably the medical provider you trust the most. So that's probably, if anyone, the person you're going to have the most in-depth conversation with and the person you're going to actually trust the most. But I mean, it is important to talk about specifically facts around people of color in this vaccine, how many were involved in the clinical trials, that they did sub-analysis of each individual subpopulation. So regardless of which racial ethnic group we're talking about, for side effects and did not see any trend of side effects among one particular group. So it's important to talk about all that information. The main scientist who developed the Moderna vaccine is an African-American woman, female scientist. So that would be important to share with people as well. In the third scenario, again, this is an individual who's not perceiving personal risk of COVID-19, but maybe this person has a relationship with their grandmother or with other people who may be vulnerable. So it's finding different angles with different people. Or why does he think COVID-19 is not a big deal? Does he not believe the statistics around death, et cetera? And then the main thing about the vaccine, you can go to the next slide, Tim. The main thing about the vaccine, though, is it doesn't matter which vaccine you get for most people in most situations, that really all three of them are great at preventing serious illness, so hospitalization and death. And so that's what I focus on with people, because the reality is they may not have a choice in which vaccine they have access to. It's going to just depend on where they're going to get their vaccine. So there are a lot of different strategies, again, that you can use. So in New York State, I actually do a 90-minute webinar weekly for the substance use disorder treatment system, where I present facts on the vaccine. I update it weekly, depending on what's going on in the news, and then do a live Q&A. So that's, I think, been helpful in talking about hesitancy. I think people want a quick fix around hesitancy, and it's just not. These are best to be one-on-one conversations from a trusted messenger to a person who's hesitant. And it may be multiple conversations over time. The other thing that I think is a lot of people don't realize that people with substance use disorder are uniquely at risk for COVID-19. So if you've had a substance use disorder diagnosis, regardless of which diagnosis that's been active in the last year, you are at increased risk, with those with opioid use disorder at the most risk. So it's important to let patients know that. If they also have comorbid mental health issues, persons with bipolar disorder or with schizophrenia or other schizophreniform diagnoses are also at highest risk for complications due to COVID-19. So I think sharing that information is important. And the other thing is when we look at stats that are reported on a state level for how many people are vaccinated, how many adults over 18, how many of the total population, et cetera, it kind of gives you a false sense of security, particularly in New York State, for instance, because we go, oh, we're doing pretty well compared to other states. But we need to remember that is not necessarily drilled down in our own patient populations that we're seeing. So if you look among the Substance Use Disorder Treatment Center in New York State, our stats among vaccine acceptance, both for staff that staff our programs and among patients in our programs are lower than New York State overall stats. So those are some of the things that I think are important to keep in mind.
Yeah, very good comments, and thank you. This is recorded, so the audience will have access not just to the slides, but to obviously the recording. Dr. D'Orazio, Dr. Perrone, do you have any other final comments?
I think Dr. Ramsey really summed it up well. I think maybe saying in a different way is that you need to read the room and use the credible messenger to deliver that information. And if you as the provider have a really good rapport with your patient, you're very likely to be able to convince this patient that it's the best thing to do for them. But if you don't have that rapport and you are not perceived as a credible messenger, you need to use people who connect with your patient. And whether it's race or age or some demographic, you need to use a credible messenger to convey that point to your patient.
Yeah, excellent. Thank you. Well, thank you all. In the interest of time, I'm going to move on to the final thought. I want to thank our panelists for some really good discussion on xylazine and drug adulteration. Today's final thought is in the theme of adulteration. This is the Jake Walk Blues from Austin, Allen of the Jug Washboard Band, 1930. And Jake Walk Blues is I can't eat, I can't talk, been drinking mean Jake. Lord, now I can't walk. Ain't got nothing now to lose because I'm a Jake Walking Papa with the Jake Walk Blues. Listen here, Papa, can't you see? You can't drink Jake and get along with me. You're a Jake Walking Papa with the Jake Walk Blues. I'm red hot mama that you can't afford to lose. Listen to your daddy. I'll tell you once more, if you're going to drink Jake, don't you knock at my door. Listen here, mama, call your hand. I'm a Jake Walking Papa from a Jake Walk land. I'm not good looking and I'm not low down. I'm a Jake Walking Papa just a hanging around. Now I made this song and it may not rhyme. I'm a Jake Walking Papa just having a good time. My daddy was a gambler and a drunkard too. If he was living today, he'd have the Jake Walk too. When I die, you can have my hand. Gonna take a bottle of Jake to the promised land. Now I'm feeling kind of drunk, brother. Be wearing Jake socks after a while. You know that you call them iron socks. You know, I bet you don't know one from the other, brother. Which is the other? This is in reference to ginger Jake with adulterant triorthocresal phosphates, which caused an axonopathy and a particular way of walking that was lifting legs up and flopping. So people called it the Jake Walk, and was first described in popular culture in one of the first blues records recorded by the Jug Washboard Band. So from 1930, Jake Walk Blues, ginger Jake paralysis. So thank you all for joining. Mark your calendars for the next Addiction Toxicology Case Conference, September 3rd, Friday, 1 p.m. And again, these slides will be available as well as recordings on both the ACMT and ACM website. And please complete your feedback and suggestions for future topics. Thank you again, panelists, for joining today. I'm Tim Wiggins, and we will see you in September.